This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and tonight I have with me my colleague, Dr. Waleed. And we're going to have a little discussion tonight about some of the efforts underway, at least in our camp, to diminish healthcare expenses. So right now, we're in the year 2011. We have this extraordinary change that's occurring in the American healthcare system. There are all sorts of efforts under reform. And I thought it would be an interesting thing to do to more or less present over using television to discuss some of the things that we as physicians talk about when we have our meetings. So what I'm going to do tonight is go through a little recapitulation of something that we did earlier in grand rounds at the Medical Center of Central Georgia, some of the things that we talked about the role of physicians in minimizing healthcare expenses. And I think that's an important thing for the public to understand, that the physicians are trying to pay attention to this problem and participate in a national dialogue. So I'm just going to show a series of slides, and maybe we can start with our first one. If we can see our first slide, we'll see what happens. So basically what goes on in the American healthcare system, physicians are the people that basically they write the orders, they more or less spend the money that drives these costs up enormously. And it's important for physicians to play a role in making those costs go down, and I'm just going to show a series of slides on that issue. So next slide. One of the things that I think is extremely important to understand is that society places a great high value on human life and wants and expects the very best high-quality medical care that can be obtained. And so that's what we're going to try and do. And next slide, please. And it's important to understand, I think, as the American public looks at the American healthcare system, that there are substantial non-economic parameters are out there. If one listens to debates on television, many times people are talking about money, but there's a lot more to healthcare than that. And you could say that it's really a healthcare organization is really in a way like a secular church. We're trying to give people physical salvation. We can't give them spiritual salvation. And if you can't get into a hospital, then you may well not make it. And so it's very important to have an open entryway into the healthcare system. Next slide, please. And I'd like to quote the Navy hymn about the difficult thing that people find themselves in when they're sick, and they're in peril on the sea. They cry out for help, and it's the sort of thing that we as a society need to afford people. We have a little picture of Rembrandt. This is Christ raising Lazarus from the dead. It's not something we can necessarily accomplish, but we certainly want to heal the sick if we can. Next slide, please. And the problem is that all the quality of care that the American system has comes at an increasingly high cost. And let's look at some of those numbers. And this just shows the extraordinary amount of money that we spend in America on our healthcare system. And it's just going up year by year, and it's actually a non-sustainable number. Next slide, please. And this is kind of a breakdown about the amount, how healthcare dollar is expended in our country. And there are different ways to calculate this, but one can say that an enormous amount of healthcare is spent in a hospital setting, and rather less in regards to physician services. Next slide, please. And we can kind of look at the amount of money that's spent in the American healthcare system and compare the GNP that we spend, which amounts to about almost $2 trillion a year, with the different GNPs around the world. And so we can see the American healthcare system really is spending about the same amount of money as France and a bit more than England. In fact, 5 or 6 cents of every dollar spent in the world on anything is spent in America on our health care. Next slide, please. But the problem is that many people challenge the results of how well the healthcare system is working. Next slide, please. And this sort of demonstrates life expectancy with the amount of money spent on GNP. And we can see the United States spends a huge amount of its gross national product on healthcare, yet the life expectancy of our citizens is really not higher than a country like Japan. We can see that the Japanese live far longer than we do. They seem to be healthier. The point I'd like to make with this slide is that a lot of the statistics involved in longevity are not necessarily related to the amount of money spent on healthcare, but may have other factors. For instance, if one plotted the obesity of different countries, you could see the Americans are somewhat more obese than other places, and thus their life expectancy is negatively impacted. Next slide. So just to restate what's been said, we just cannot continue to expend the amount of money that we're spending now, and we need to do something about it. And so what are some things we might be able to do? Next slide, please. Well, one of the things to do would be to increase healthcare efficiency. And that's what we'd like to try and accomplish. We'd like to try and have a patient, when they come to the hospital, to get the very best treatment with the smallest amount of expenditure. And the difficulty occurs when there's an excessive amount of government regulation or too much busy work, and the physicians wind up practicing defensive medicine, and optimal outcomes are not provided that way. Next slide, please. So the other thing that I think Americans can understand is there's less and less money for anything. The economic times have been difficult. The amount of money available to provide health care is diminishing. We're not going to have the same amount of money in the future that we've had in the past to do these things. Next slide, please. And one of the things one can see are Medicare cuts and Medicaid cuts. There's just not enough money to spend, and we've got to, as a society, start to face that issue. Next slide, please. So the real dilemma that's basically facing the American people and the whole healthcare system is how do we decrease healthcare costs? And there are sort of two roads to go down. One is to impose rationing, and by that what I mean by that is that it would be very difficult to get any kind of test that you need as a patient. There'd be a lot of paperwork to do before some kind of procedure would be obtainable. There'd be an enormous delay. It would be impossible to get the routine care that people expect. Well, unless we do something about the cost, that's what's going to occur. The other thing to do is to increase efficiency, and that's what we're going to talk a little bit about. And I would basically say the government has their plans about how to increase efficiency, but we'd like to talk a little bit about some of the things we're attempting to do locally in increasing healthcare efficiency. So let's see our next slide here. And this, what I'm really addressing here, and I'll just tell the TV audience, this is something that I'm speaking to physicians about. And any physician, or maybe there's some watching, they know what it's like to be impinged upon in their treatment of their patients by external mandates, different kinds of regulations, different kinds of paperwork, and that seems to be the wave of the future. So the plan that's out there that seems to be propagated is the idea the government is going to progressively, along with insurance companies, ratchet down on clinical decision making. And in some ways, that's the fault of physicians. I think physicians have not been enough involved in trying to improve the system. And there's some reasons for that. Next slide, please. And I'm just going to say to the audience, these are the things that face physicians. One may well wonder, well, we have all this extraordinary increase in expenses. What are physicians doing? Are they attempting to do anything? Are we just going to let the government run the system and that'll be it? They're just passive spectators, even though their life work is involved in making the healthcare system work. Here's some of the problems physicians face. One is their Federal Trade Commission regulations. One of the things that used to happen is that medical societies had a great deal of power about regulating different kinds of physician behaviors and to make sure things worked well. And those powers have largely been removed. There are Stark regulations. That's sort of an arcane set of regulations that prevent hospital and physician collaboration on many issues. Another issue that troubles physicians is the absence of cost information. So for instance, if I'm operating, maybe I'm doing a brain operation, and I would like to know what a sponge costs, how much it costs, it's almost impossible to find out what things really do cost. A physician just does not have access to that kind of information. Another thing that's going on, I think, and I just like say this in this public venue, is that there's been a transformation of physicians into healthcare providers. There's nothing wrong with being a healthcare provider, not anything at all, but the physicians have a certain corps d'esprit that needs to be preserved, a certain kind of obligation to their patients that can be impinged upon if their I guess useful powers are abridged. Another problem is a bureaucratic control. So what happens with physicians these days as they go about trying to do their work is we're just overwhelmed with regulations from every corner. And another thing, which I think is a central problem, is the rupture of the doctor-patient covenant. There's a connection that traditionally exists between a patient and his physician, and that's a very sacred, holy covenant. And for many reasons, that's not as strong, I would say, now as it was when I started my career. Next slide, please. So what I'm going to talk about a little bit is some of the ways that we can maybe make the system work more efficiently. And there's a good analogy with when one flies on an airplane. The pilot of that airplane cannot make a mistake, nor can a physician. Next slide, please. And so, in fact, if physicians do make mistakes, there's no way they would consent to ever make a mistake knowingly, and their malpractice system gives them a huge nip if they do make mistakes. And what that does is it makes the physician very loath to not order the last test, not do the last study. And so there's an enormous amount of defensive medicine that's driving up the cost of health care. And to do something about that preserves public rights would be a really useful thing to accomplish. Next slide, please. So I'm just going to continue talking about hospitalization and airline travel. I'm sure most people in the audience have had experiences with both. Next slide, please. So the same way that the airline tries to get people efficiently into an airline seat, hospitals try and get them into a bed in an efficient fashion. Next slide, please. And there's the same kind of things takes place on an airplane flight as a hospital admission in a way. There's preoperative screening, there's actually the operation, whatever that is, and then the discharge when one leaves the hospital. So I'm going to talk a little bit about the preoperative screening that occurs when one enters a hospital. Next slide, please. So we have a lot of papers on this subject. Let's keep going. And I'm going to go through a series of papers now, and just to talk a little bit about this. One of the things that I think the public needs to understand is the disease processes are not simple. It's rare that one has, shall we say, just an infected foot. The foot is infected for other reasons. There may be a diabetic issue. There may be a circulation issue. So there are other organ systems involved. So when this particular discussion was about spine surgery and the comorbidities that are present. So let's just go through a few of these. Next slide. And these are, if one has some kind of operation on their spinal column, and we reviewed a lot of patients to see what was happening, and we have a tremendous number of patients that have other diseases. About 78% have hypertension, all kinds of problems with our patients. About 20% have substantial coronary artery disease. Next slide, please. And what these comorbidities do is that they become more evident as the patient ages. So when we have a patient that's an elderly patient, shall we say, in over 70, they're going to have all kinds of other diseases. And these other diseases, as we'll see, will drive the cost of surgery up. Next slide, please. So this is just a little quick thing about what the economic impact of these comorbidities are in spine surgery. And I won't belabor the point, but they're substantial. Next slide, please. And what this does is that it has an enormous additive effect on the actual cost of the patient's hospitalization. So this turns out to be a big deal. Next slide, please. And one way to track this is to look at something called the Charleston Comorbidity Index. And I'm not going to spend too much time on this subject, but the higher the comorbidity index, the sicker the patient is. And this just shows our experience in how these numbers look. Next slide, please. And we reviewed our patients, and we can see that most of them had almost no comorbidity. They're about 0. But as one goes to the right of the curve here, the risk increase dramatically, but the numbers diminish too. Next slide, please. Well, where all that is going is that when the federal government allows for different amount of money to be paid to hospitals for different interventions, they don't take this comorbidity into consideration. So what that does is it skews the demand-supply curve. So it turns out to be a fundamental error. We're going to talk a little bit about obesity and age. I'll just make the same thing goes on here. There's a really big impact of older patients and patients that have more adipose tissue on their body. Their costs go up a lot too. Next slide, please. And I'm just going to keep talking about this. And one of the things that occurs in our patient population is many people are unaware they have diabetic issues. And because of the diet difficulties that we have in our country, many people have, unbeknownst to them, have problems with glucose metabolism, and this causes substantial increase in cost and length of stay, and this just kind of talks about that. Next slide, please. And this slide just talks about all these occult comorbidities. A comorbidity is something that a patient has that it goes along with the disease process. So for instance, if you're obese, it's common to have some heart problems. It's also common to have some diabetic difficulties and a host of other things that go along with that disease, arthritis, for instance. Next slide, please. And just this is what we can do to screen these patients prior to their operative intervention. So if we can pay attention to the other diseases that are going on and treat them, then we can actually give the patient a better result and also diminish the amount of money that's being spent to get that patient healed. Next slide, please. And so this just shows what happens that if we screen our patients successfully. And in this case, we had an internist to see the patient prior to operative intervention. An internist is a doctor that specializes in these systemic diseases. So the idea of getting an extra doctor involved means that we can identify these problems and then diminish the patient's stay, diminish complications, and have the patient treated for less money. Next slide, please. This is just another patient that we wanted to talk about, and another group of patients we wanted to discuss. And these are the patients that have obesity and the comorbidities that go with that, and they're readmitted for an infection. Next slide, please. And so we can see that in this particular group of patients, there's an inpatient and an outpatient group. And the patients that are outpatient turn out to be a lot healthier. And these healthy patients that are not as obese and don't have as many comorbidities can actually be treated for far less money. Next slide, please. So what we want to try and do is find ways to save money. And one big way to do that is to have patients have outpatient surgery. It turns out to be far less expensive, and understanding which patient can have this and which patient cannot is the physician responsibility, and we want to encourage our colleagues to pay a lot of attention to try and minimize these costs. Next slide, please. And these are some intraoperative factors that we pay attention to. We'll go quickly here. Next slide, please. There are just a list of some of the patients or some of the papers that we've presented on the subject. Next slide. And this is using different kinds of material to fuse a patient's neck when they're getting a neck operations. And sometimes what we can do is take some of the patient's bone out of the hip. The other times we can use so-called cadaver bone and see which, they both work similarly, but see if there's a difference in the cost. Next slide, please. And we can see that in fact there is a difference. And so one of the things that we need to pay attention to are what different kinds of materials cost when we do our operations. Next slide, please. And another thing that's commonly used in spine operations are drains. They're put in to prevent blood clots and neurological deficit. Next slide, please. And this just shows what happens with drains. And so it appears that sometimes the use of the drain it can be a little more expensive than not using it. And this is something we just need to understand, whether it's good or bad. We need to, physicians need to pay attention to this kind of figures. Next slide, please. One of the big things that happens in America is that if you come into a hospital and you have a low-grade fever, the idea is that you have to stay in the hospital until that fever goes away. So we reviewed some statistics with some of our patients about this. Next slide, please. And we looked at patients that had post-operative fever and not post-operative fever with different kinds of operations. And it appeared that people that had a low-grade temperature after an operation stayed an extra day or two in the hospital, costing a huge amount of additional money. Next slide, please. And what this slide basically demonstrates is that, that if one has a low-grade temperature after an operation, it would be possible to go home safely and not risk an infection. The infections are only start to occur in our patient population when the temperature goes over 102. So what physicians need to do is they decide whether or not the patient can go home or not, is not pay such a huge amount of attention to a very low-grade temperature, and that would save a huge amount of money. Next slide, please. Now, one of the things that's going on the American public needs to be aware of is the federal government has different kinds of regulations put in there for good reasons. The government doesn't want particularly Medicare patients to be tossed out of the hospital prematurely with the idea that the hospital might make some money on doing this. So they put practice guidelines in place to prevent that. And one of the issues in those guidelines is that it is very, very bad to send a patient with a low-grade temperature out of the hospital. And it's kind of a federal mandate. Next slide, please. And what that does is it causes the patient to stay in many situations an unnecessary length of time, driving cost up. And this is the kind of government regulation that the citizens need to know exists, and it might not be in their best interest, and it may be driving the cost of health care up. This is another, just brings the point across about what government regulation can and cannot do. And government regulation does a lot of good things. It appropriately protects patients. It's good to have this check on getting patients out of the hospital prematurely, but excessive regulation really can cause a bad patient care. Next slide, please. And another issue that comes up is efficient discharge. So just like getting out of an airplane quickly, getting out of a hospital turns out to be a big deal. Next slide, please. And this is one of the studies that we did just to try and see if it's possible to get our patients out of the hospital a little quicker than we normally do. Next slide, please, and what might be accomplished. And this is a paper we presented on the subject. Next slide. And what we attempted to do was to put a little checklist with our patients to try and get the patients out just about at the crack of dawn, if that was appropriate. Next slide, please. And this just shows we changed our discharge arrangements. We're able to get the patients out much quicker than earlier. Next slide, please. And what that did is that it had a very substantial financial benefit. And we attempted to see what the etiology of delays were. These are some of the reasons for delay. But physicians have historically not paid a huge amount of attention to early discharge, just because they were focused on other things. And so the patients just wound up staying an extra bit of time, causing a huge increase in cost. Next slide, please. And this just you get a sense of how much can be saved by doing this. We saved a lot of money. Next slide, please. And one of the things that people need to be aware of is getting into a hospital bed needs to be efficiently done, and so we work with hospitals to do that. And if a patient leaves the hospital in the afternoon, that makes that bed unavailable for another patient to come in. One of the big problems we have in the whole healthcare system when hospitals go on diversions. And diversion means you cannot get into the hospital. And many times emergency patients cannot get in the hospital. So it's very important to make those beds available when it's appropriate to do so. Next slide, please. And one of the things we talked about is lots of problems occur if a patient is readmitted within 30 days. So whether or not this is an appropriate penalty, whether this is good or bad, if the patient comes back a little bit later, that's a moot issue. We could talk about it another time. Next slide, please. So just talking about cost awareness, it's a big important issue. Next slide, please. Now, probably my final slides are on the absence of any economic analysis in our medical literature. Next slide, please. And we can see that in neurosurgical literature and also in orthopedic literature, very little attention is paid to economic issues. Next slide, please. And this just talks about this is the percentage of articles in neurosurgical literature, orthopedic literature, and cardiovascular literature that have in the outcome analysis, they pay any attention to what anything costs. And you can see the numbers are very, very small. And so physicians need to pay a lot more attention to what things cost in order to prevent excessive government regulation that can make things much worse. Next slide, please. And this just shows the standard of care articles and practice guidelines that have been in the neurosurgical literature over the past decade or two. And only about 8% of those articles in our standard of care pay any attention to economic expenses. So standard of care is being, enforces a certain kind of treatment with no attention to what it costs. And understanding what things cost would be an enormous benefit to the American people. Next slide, please. And I think I'm summing up here, it's very important, I think physicians want to do this, is to put the patient first. Next slide, please. And one of the things I think the public needs to be reassured about, when physicians receive their MD, they take an oath. There are all kinds of different oaths. The most ancient of those oaths is the Hippocratic Oath, and it basically pledges the physician to do that, to put the patient first. Next slide, please. And I won't get into the nuances of this, but there's been, over the years, other oaths have occurred to be a little more contemporary. The Hippocratic Oath is about 2,500 years old. So these oaths come along, but the takeaway message is every physician is bound by ethics to his patient. And it's not merely an economic issue, as many people in the government may imagine. Next slide, please. So this is a picture of marks being removed from Eastern Europe when the communist world collapsed. And in many ways, the models that are being put across to the American people in some way mimic the Soviet model. The idea of centralized care, the idea of the government oversight, and this didn't work, did it? And it doesn't comport itself with our American system. Next slide, please. And one of the things that it turns out to be important is the idea that physicians are a guardian of healthcare resources. They have to expand what they do, and just because the problem is so extraordinary. And if we don't do that, there's going to be a big problem. Well, all right. Thank you. And Sammy, we've had a nice little chat. Thank you for listening. A lot of this is your work. We continue to go forward.
Under your supervision, Dr. Robinson.
Well, thank you. Thank you, Sammy. And so we'll be talking some more about this, and on the show, we'll be discussing what's happening as the government changes the whole matrices of the American healthcare system. And if they're doing something well, we're going to say it's good. If they do something bad, we intend to talk about it. So thank you, and good night.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions. treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.